Now, once again, Raymond Arroyo.
Welcome back to The World Over. According to the World Health Organization, about 5,000 people have died after contracting the Ebola virus, mostly in the three most affected regions in West Africa: Guinea, Liberia, and Sierra Leone. The World Health Organization reports this week that the rate of new cases is slowing significantly. At the same time, policymakers around the globe are instituting travel bans and quarantines to stop the spread of Ebola in their respective countries. What is the best way to contain this virus? Joining us tonight from Monrovia, Liberia, via Skype is Brown University medical professor Dr. Timothy Flanigan. He's on the ground battling Ebola on the front line, and here in studio is Dr. Mark ABRUZZESE. He's the chair of the Infectious Disease Control and Prevention Committee at Sibley Memorial here in Washington, D.C. And joining us by phone is Dr. Meryl Nass of the Institute for Public Accuracy. Thank you all for being here. I want to start with you, Dr. Flanigan. What are you seeing on the ground? What are you most in need of as you combat this terrible virus? And I know you've been in the midst of it for 2 months now.
Yes, well, I came over at the very end of August, actually the last flight in from Accra in Ghana, and I joined the Catholic Health Network, and they were doing working incredibly hard to take care of patients with really very, very little. And at that time, things were, there's no other way to describe it, they really were out of control, and the system was overwhelmed. There were not enough beds in the Ebola treatment units. The efforts to take care of patients with Ebola just could not keep up with the number of patients that were ill. There were people that had died and dead bodies that could not be properly taken care of. And so the infection was continuing, and it really was spiraling out of control. We know how this is spread. We know that touching a body of someone who has died, or touching body fluids, or taking care of somebody who's infected without appropriate precautions will spread it. We had some good news recently. The international efforts have really kicked in. The Liberian medical community has really worked incredibly hard under very difficult conditions. And the number of new cases in Liberia, and particularly here in Monrovia, which is a huge challenge because it's a big, crowded, very poor, congested city, the numbers appear to be down. It doesn't mean we should lessen our efforts. We really need to redouble them, because one single case of Ebola is an outbreak. So we appear to be making progress, and that is really important.
Dr. ABRUZZESE, there seems to be a quasi-containment at this point, at least in Africa. I mean, the World Health Organization is still projecting 10,000 cases between now and December, 10,000 as we move forward. Your thoughts?
I can't predict the number of cases going forward, but as you said, and as we're hearing from the people on the ground, that containment, the #1 principle in infection control and prevention, is to contain the process. And I think that we've contained it geographically. Now the boots on the ground, so to speak, will help us to further contain the process. So as we look at it from our standpoint on this side of the ocean, I think that we as a system are better equipped to handle the sporadic cases that we'll see.
I stand corrected, and I just checked my notes here. The World Health Organization is projecting 10,000 cases a week between now and December. That's an awful lot of cases.
It sure is, and I think that there'll be better reporting to maybe bring those numbers up, but I do believe there's going to be fewer transmissions as the word gets out through the countries where it is absolutely an epidemic proportion.
Dr. Flanigan, what is the first rule you all have when someone is brought in? How do you contain this? What's your first rule of prevention moving forward?
The #1 rule is that this virus is spread from someone who is ill, not from someone who is well. So a person who is ill with Ebola, the #1 rule is to identify it and to recognize it, and that's done through triage. Then the second is to provide care in a way that you limit the amount of contact with that patient. We actually use what we call no-touch care. That's difficult for those of us who have been trained in more traditional care, but we try and make sure that patients are adequately hydrated, that they can receive medications for other causes of fever, such as malaria, or antibiotics for antibacterial infections, and limit the contact. Then, of course, we try and use the Clorox or chlorine washes, which is effective at killing the virus. And then we, of course, use appropriate protective equipment, which we call PPE. And there have been a lot of efforts to make sure that it gets out there, that the trainings are done correctly, which they are. And that is what is dramatically better. I have to say, when I first came over, the fear here was palpable. People wanted to run and hide. No one wanted to go to the treatment units. And that, of course, made it incredibly difficult to control the epidemic. In the last few weeks, the community engagement is really totally different. Communities are now saying we have to protect ourselves from getting Ebola. So the communities are on the lookout. They're making sure that folks that are ill go to the Ebola treatment units. There's much wider availability of testing with the Ebola PCR. So the whole system is working better, from diagnosis.
Okay, but when somebody, Dr. Flanagan, when someone comes in, though, you have a policy where once that person, whoever carries that family member in or friend in, that individual is then quarantined, correct, for 21 days?
Absolutely, because that person has touched or been in the same house or been in very close proximity to someone who is ill. So that is the critical issue, that it's an ill person that transmits the virus. And when you're in that close contact, you definitely do want to observe yourself closely and make sure there's no further contact to break the chain of transmission.
I want to bring in this next topic, and we're seeing this play out here in the United States, really around the world. There is a nurse, former CDC employee, Casey Hickox. She was quarantined by New Jersey authorities when she arrived at Newark Airport following time in West Africa. Now she had a fever reading, though she did not test positive for Ebola. She was quarantined in New Jersey. She put up a fuss. They sent her home to Maine. Now she's refusing to abide by a 21-day quarantine. Today she went for a bike ride, and the Maine governor is threatening to step in. Here's what Casey Hickox is saying.
To prison me in my house for 3 weeks when you don't know whether I will develop disease or not, and when I don't have symptoms. I am self-monitoring, but I'm not willing to stand here and let my civil rights be violated when it's not science-based.
What do we make of self-quarantining? Dr. Abruzzi.
I think that the word quarantine is one that we use when we specifically tie people down, so to speak. But she doesn't need to self-quarantine. She needs to self-observe her symptoms. She needs to self-monitor. And as long as these people, and believe me, every one of these folks are educated folks. They went over to Liberia for a reason. They've come back. They know what the symptoms are. They do not want to be 4 days delayed in reporting their illness. So they will self-observe adequately and then self-report if they have a problem.
Okay, but we had Dr. Craig Spencer in New York. He didn't self-report. He was out bowling, and he went to the subway, and he got in the Uber car, and he went out to restaurants, and then he started to present symptoms. So he was carrying the virus all along. I want to bring Dr. Meryl Nass in. Your take on this, is this a threat? Should there be a mandatory 21-day period of self-quarantine at home for anyone who's gone to this hotspot, particularly in close proximity to those who've been affected and infected by Ebola?
I'm actually agnostic on that question. I think you have to realize that Médecins Sans Frontières has had about 1,000 Western doctors and nurses come and serve in West Africa, and Dr. Spencer is the only one of them who has developed Ebola after he got home to his home country. So that's about a 0.1% risk. There are many other people coming back from West Africa, and we are not quarantining them. The nurse actually tested negative twice for Ebola, and yet she's being quarantined. The American ambassador to the UN has just gotten back from a fact-finding trip to West Africa. She hasn't been quarantined. So right now we don't seem to have any uniform standard, and we're not really assessing the risk on any kind of, regular way. And I think if we do start quarantining people, which I don't think I'm in favor of, I think that will only delay cases in the U.S. because some people will come in from places that we didn't know had Ebola, but may turn out to have been exposed, in ways that we're not aware of, just as the nurses were in Dallas.
Yeah. Dr. Abruzzi, this is an interesting point. The CDC this week released a poster. And in that poster, the quote is, and I'll just read this, droplet spread happens, droplet spread of the Ebola virus, when germs traveling inside droplets that are coughed or sneezed from a sick person enter the eyes, nose, mouth of another person. Now, the CDC previously said this was not airborne, could not be airborne, which contradicted that 2012 Canadian study on Ebola, which said it could indeed, and they had strong suspicion that it might be airborne. Your take on this, and shouldn't this send off some alarms for public policy folks? I
believe that we talk about different kinds of spread, and droplet simply means that we have it in a body fluid. It's not aerosol, which is unlike influenza virus, which
kills a whole lot more people than Ebola in the United States anyway.
Absolutely. And so we're really talking about if somebody happens to cough and happens to have some bloody secretions and you get exposed to that droplet, which is a body fluid, it's still body fluid spread. It's not.
Yeah, but it's airborne. I mean, it's traveling outside your body. You don't have to touch me to get it. If I sneeze and I'm in the theater and you're in front of me and it lands on you and you inhale it.
And these are the people who are most sick. Keep in mind the 40 people who were in touch with Mr. Duncan before he entered the hospital. He was sneezing, coughing, touching all those people. Nobody is sick. So,
Dr. Nass, your take on this?
Well, I think CDC has acknowledged for many years that Ebola may be transmitted in aerosol droplet nuclei. And that's why it's a BSL-4 organism. It's designated in the maximum containment. It has to, people who do research with Ebola have to have a separate air supply from the lab that they're working in. And that's because it is acknowledged by CDC in a number of documents that aerosol exposure is a potential problem. And in fact, healthcare workers are advised not to perform aerosol-generating procedures on patients who are suspected of having Ebola. And if you're on an airplane and you think a passenger may have Ebola, you are supposed to put a surgical mask on them so that if they're coughing or sneezing, there will be some confinement of these droplets.
But this seems to be a reversal, though, for the CDC, yes, or at least in a latter-day admission that this indeed can be transported through the air in some way.
Yeah, exactly, because they did say clearly that it couldn't be transmitted through the air. Then they put out the poster that said it could in droplets, and now they've taken back the poster, and we're waiting to see what they're going to come up with next.
Okay. I want to move on to what Chris Christie is doing. A number of other governors in other states, they're this is an ad hoc system we're seeing, ad hoc rolling policy. Chris Christie is responding to criticism about that mandatory 21-day quarantine in New Jersey for anyone returning from an Ebola hot zone. He thinks it's necessary. Listen.
I think folks should understand part of the sacrifice is going over there, and the remainder of the sacrifice is when you come home. If you've been, remember, a healthcare worker directly exposed to the virus, or now members of our military, have to be quarantined for 21 days. That's common sense policy. I don't know when the White House is going to get around to admitting that and not, giving us 7-minute lectures from the South Lawn, and just get to work. And that's what people want. They want their leaders to do things, and that's why Republican governors and Democratic governors have taken the same step that I did, and we're happy. New Jersey is proud to lead on this, to lead in the area of common sense. That's what we're doing, and we're not changing. I don't care what happens. We are not changing our policy.
So Christie says he's not changing his policy. This is bipartisan. You've got New Jersey, Illinois, California, New York. Isn't this being prudent, Dr. Abruzzi?
I don't think that they are looking at the facts. I don't think that they've looked at what we've learned over the past month and a half of dealing with this crisis over in West Africa. It simply doesn't follow what our data would tell us we should be following. We don't need to quarantine people who are well coming back from these countries.
But at what point, how do you figure out, I mean, if I'm carrying, because there are people like the doctor in New York, he didn't test positive until he started showing signs and presenting. And the question is, at what exact point do you become infectious? Is it when your temperature is 99, 101, 103? All this metric keeps shifting. So it does make novices and public policy experts and public servants a little wary about releasing somebody who could potentially be infectious on their population.
Yes, sick people are infectious to those around them. People who aren't not sick, or like Mr. Duncan, are not infectious to those around them. We heard it from the people that are over in that Liberia dealing with the situation. We've seen it in action here with Mr. Duncan's case. So to quarantine people who are not sick does not make sense because they're not infecting people around them.
Even if they could be carriers. You
Absolutely.
would be against
These people,
quarantining them.
Absolutely. These people are carrying Ebola in very low viral loads initially. They then go on to develop a viral load that's high enough to become infectious to others. They'll be symptomatic.
I want to show you this. This is President Obama. Dr. Nass, I'll get you to respond to this. Remember, the military is being quarantined. Any military returning from West Africa, they have a mandatory 21-day quarantine. Not so for medical workers. Listen.
The military is in a different situation, obviously, because they are, first of all, not treating patients. Second of all, they are not there voluntarily. It's part of their mission that's been assigned to them by their commanders and ultimately by me, the Commander-in-Chief. So we don't expect to have similar rules for our military as we do for civilians.
There seems to be an inherent incongruity in that bite where the president is quarantining military personnel who are far removed from the infectious individuals, and yet medical personnel are left to their own devices and can self-quarantine or not. As a public policy matter, is that a good idea?
I don't think it's a good idea to give mixed messages, whether you're part of the military, part of the government, or part of the civilian medical teams. I believe that we should all be doing things the same way so that the message to the public is uniform. It certainly would help to build confidence of the public that the Centers for Disease Control, the public, understand that it is a voice of medical reason, and that going forward we should probably talk in the same language.
Before I let Dr. Timothy Flanigan go, I just want to ask you about your personal decision to travel to Liberia to potentially expose yourself to this Ebola virus. I know some physicians you've worked with have contracted it. Thank God they've recovered. How much of your faith drove this decision to go? I mean, obviously you're training individuals at Catholic institutions. Tell me about that decision.
Sure. Thanks for asking about that. So about almost 2 years ago, I became a deacon in the Diocese of Providence, and I was the chief of infectious diseases at Brown University, and I stepped down to give myself a little extra time, but I'm working full-time as an infectious disease doctor as part of a major university, and along comes the Ebola epidemic. And I thought, gosh, you know, this is something I understand. We have a good sense of how this disease is transmitted. We understand that when folks are sicker, the viral load rises, they're at higher risk of transmission, and that it is possible to protect oneself. So I thought, here's a place that it would be natural to make a contribution. So at the middle of August, I started to email around, and I was lucky enough through Caritas to reach a wonderful nun, Sister Barbara Brilliant, who is a Franciscan missionary Mary, who works within the Catholic health sector here. And she said, sure, come along as a volunteer. I, of course, purchased evacuation insurance, but at the very bottom of it, in fine print, of course, it says, by the way, if you get Ebola, we certainly cannot help you. But I thought, you know, as an infectious disease doctor, I understand this, and I think I can really decrease the risk so that it's negligible. You know, my wife said, be careful and take care of yourself. And my colleagues at work said, be careful and don't do anything foolish. But if you can make a contribution, go for it. So I was able to volunteer and come on over. And in fact,
well,
many people come over.
We certainly wish you the best there, Dr. Flanigan. We're running out of time here, and I just want to bring Dr. Abruzze in for just one moment here. Are we going to see any sort of outbreak here in the United States, or you think this will be just one-off cases here and there, and this will be largely contained?
I believe one thing, and Dr. Flanigan said it earlier, that one case is an outbreak. So I do believe we'll have some coming over from overseas. I believe our hospitals and hospital systems are well prepared to take care of those individual cases. Within the District of Columbia, for sure, we have our DC Hospital Association, Department of Health. Everybody's working to operationalize good care for the people and moving them to appropriate places that can care
Very
for
quickly,
them.
Travel ban or no travel ban seems to have worked in these African nations.
I believe containment of epidemic areas are important. We're not quarantining and having travel bans on people with influenza. We need to be diligent to watch people for 21 days, but travel bans in general are probably not going to help us.
Doctors, thank you all for your insight and important work. You can learn more about Dr. Timothy Flanigan's mission in Liberia by checking out his blog, timothypflaniganmd.com. And you can get the official information about Ebola by visiting the Centers for Disease Control website at cdc.gov.